Okay, so hello and welcome back. Today we'll discuss pathobiology of obesity. Just to give you a heads up, I will tell you a very shocking statement, and that is obesity has overtaken smoking as the greatest risk factor for development of cancer. Though obesity has been well known for as a risk factor for development of insulin resistance, type 2 diabetes mellitus, hypertension, dyslipidemia, and cardiovascular diseases. Therefore, making it a very important topic to understand here. As you can see in the image in the center, I've tried to show an adult male having a central obesity. Central obesity plays a pivotal role in development of insulin resistance and then a cascade of other diseases like diabetes, dyslipidemia, hypertension. Okay, but obesity is not limited to adults. There are a strong genetic association. As you can see in this right image, I have tried to show a child who is overweight, having developmental delays, mentally retarded, hypotonia, and small hands, classical of Prader-Willi syndrome. It is a part of obesity syndromes. Therefore, genetic associations are also there, making it making the patient having hyperphagia. There will be never-ending appetite. This child are always on a mood to eat. Again, on the left hand side, an overweight child having this craniosynostosis, that is premature fusion of skull bones, brachydactyly, small hands, classical of Carpenter syndrome, again a part of obesity syndromes. Everything in a nutshell we are going to discuss. Okay. Definition of obesity and overweight as per WHO. It is a state of excess adipose tissue mass that adversely affects health. So, for the Western population, WHO has given these parameters. Now, first of all, what is BMI? Body mass index. It is height in weight in kgs divided by height in meters squared. This is the formula. So, if a person is having less than 18.5 of BMI, he is underweight. Normal as per the WHO for Western population it is 18.5 to 24.9. But for Indian population it is 18.5 to 22.9. This lower cutoff has been used. Anything about that, like about 22.9, that is 23 to 24.9, this is the cutoff for Indian population for overweight. And about 25, anything for Indian population is obesity. Okay, this is because Indian population or say Asian population as a whole tend to have a higher body fat as compared to their body weight. That is why lower cutoffs are being used. And similarly, for the Western population, overweight is considered to be more than 25, less than 29.9, and obesity when more than 30. Okay. Now, fat tends to be distributed differently for men and women. For men, fat usually distributes the truncal sides and intra-abdominal sides, whereas in case of women, subcutaneous tissues of buttocks, thighs, and upper arms are the usual locations. How to measure this fat distribution? A very important and an easy way to measure fat distribution is with the help of waist to hip ratio. Take a measure tape and get both the findings from waist and hip, divide them and get a ratio. If the ratio is more than 1 in men, it suggests that the patient is at risk for development of any of these conditions. But these again are the parameters for Western population. For Asian and particularly Indian population, the waist to hip ratio for men, if it is more than zero point 0.9, it is high risk. If it is more than 0.85 in women, it is high risk. Physiologic regulation of energy balance. So for that, please understand that the key locus for integration of signals is our hypothalamus. Hypothalamus is going to receive signals like hormonal signals, neural signals, cognitive signals, sensory signals. So, for instance, of a plate of gulab jamun comes in front of you. Just on the site of the gulab jamun, there are certain processes that are going to happen and ultimately lead to increase in the hunger, increase in the appetite. So, what all things are going to be there, we are going to discuss one by one. Okay, so basically, hypothalamus is our central integrator. It is going to integrate the signals. Homeostatic regulation of body weight is controlled by neurons in the hypothalamus. Now, the satiety and the appetite both has to be kept in check. Not more if they are in not kept in check, then there will be development of obesity. So first we will understand the hormonal signals. Hormonal signals from adipose tissue is leptin. Our star molecule is leptin. It is very very important. So here in the diagram we have shown adipose tissue releasing leptin. Then other hormonal signals from GIT, gastrointestinal tract, in response to meals. Whenever we are going to eat, our small intestine is going to release glucagon like peptide 1 and cholecystokinin. And our large intestine is going to release peptide YY and oxyntomodulin in response to meals. Plus neural signals from the vagus nerve and the enteric nervous system. As you can see in the image, this is our enteric nervous system and this is a vagus nerve. Both of these, in response to meals, are going to take their signals and ultimately, via these fibers, reach hypothalamus. Leptin going to hypothalamus, GLP-1 and cholecystokinin from small intestine going up, peptide YY and oxyntomodulin from large intestine going up. These are all our signals which are going to be integrated in hypothalamus. And on receiving such signals, hypothalamus is going to now start the activity of satiety. So basically, these hormones are going to act in synchrony and achieve satiety. Then what are the hormones which are going to activate appetite or hunger? That is our ghrelin. Release of ghrelin from the stomach increases in unfed state, and that ultimately leads to increased in appetite by acting on the hypothalamic neurons. And lastly, insulin and amylin that are released from pancreas also are going to be ultimately reaching hypothalamus, and they are going to contribute to energy balance. Okay. Leptin, as I said, is our star molecule. It is a peptide hormone released by fat cells. As we saw in the diagram, adipose tissues are going to release leptin. The concentration of leptin is increased when the fat cell stores are high. Okay, so you can understand in this way that whenever we are in fed state, the leptin concentration is very very high. Whenever we are in fasting state, when the fat cell stores are very low, leptin concentration is also low. So both the arrows are going in same direction. Hope you are understanding. So so for example, say here, caloric restriction phase. Okay, fasting phase. Decrease in leptin. Decrease in leptin is a powerful stimulus to food intake and intense drive to eat, hence hyperphagia. As we have all experienced, whenever we are not taking food for say 12 to 18 hours, and suddenly we are shown a good plate of biryani, we are going to give in, like we are going to jump on it. It is a rebound overeating. All credit goes to our leptin. Now, humans born without functional leptin or leptin receptors develop severe obesity from early age because of intense drive to eat. As I said, development of obesity has genetic connections as well. We are going to learn in couple of slides. Therefore, leptin and presence of leptin receptors is very crucial for our energy balance. Hypothalamic pathway is regulating body weight. Very important slide. First of all, let me explain it here only. In fed state, leptin should be low. Low leptins are going to activate the primary neurons in the arcuate nucleus of hypothalamus, which are expressing POMC, pro-opiomelanocortin. Okay, they are going to activate the POMC expressing neurons, which are going to release alpha and beta melanocyte stimulating hormone. Okay, alpha and beta melanocyte stimulating MSH is going to be released, which acts on melanocortin 4 receptors, which are expressed on the neurons in paraventricular nucleus. Are you guys with me? Leptin activating the POMC expressing neurons in hypothalamus that are releasing alpha and beta MSH. This MSH is going to act on melanocortin 4 receptors, which are expressed in paraventricle, and ultimately tell us that by please reduce energy intake and start increasing the energy expenditure, start doing some physical activity. You are in ample nutrition. So in fed state, this is how a cycle of reduction in the energy intake and increase in energy expenditure happens. On the other side, this leptin will inhibit the neurons which are expressing AGRP, agouti related, which switches off melanocortin 4 receptor. So basically inhibiting the inhibitor. So again, MC4R is going to be activated and your food intake will be like satiety will kick in, and ultimately helping us in maintaining our body weight. Same thing is being shown in this image. Now see, adipose tissue releasing leptin, leptin reaching our hypothalamus, zoomed in. So leptin is activating the POMC expressing neurons in our arcuate nucleus, which are releasing alpha and beta MSH. This alpha and beta MSH are going to act upon melanocortin 4 receptors, which is ultimately reducing our food intake and increasing energy expenditure. Also, brain-derived neurotrophic factors and single-minded one are two molecules which also act in synchrony and ultimately lead to reduction in food intake and increasing in energy expenditure. Okay, so a final word, when these meaning when these pathway plus brain-derived neurotropic factor and single-minded one are disrupted by inherited mutations, then development of hyperphagia and severe obesity occurs. Okay, so anywhere I have tried to label these places. So here I have tried to label one. So if there is any genetic condition which leads to leptin deficiency, then it can lead to hyperphagia and obesity. If there is any genetic condition which leads to deficiency of leptin receptors, then again hyperphagia and obesity. Any conditions which are going to disrupt this POMC expressing neurons, again hyperphagia and obesity. And lastly, MC4R receptors, if there is any defect, again hyperphagia and obesity. So this is all in a nutshell how this hypothalamus physiologically is regulating our body weight by inducing satiety and telling us that there needs to be increase in amount of expenditure of energy. Physiology of nutrient storage. So basically, how our body weight is being maintained. It is maintained on one side we are consuming energy, and on one side we are expanding the energy. Okay, this is how normally the body weight is being maintained. When energy intake exceeds the expenditure, that small excess energy is stored as glycogen in liver and skeletal muscles. If more excess energy is available, then that excess energy is stored in the form of triglyceride. As in the form of if I can zoom here, this is a fat cell. Okay, this is a fat cell showing a unilocular lipid droplet in which the triglyceride is going to be stored. So, whenever there was excess energy, this excess energy in the form of triglyceride is going to be stored in this unilocular lipid droplet, which has a single layered phospholipid membrane containing all the components to make or break the triglyceride. So, for instance, we are going to go on a fasting state. Say we have not eaten for 18 hours. So, the body is now in need for fuel, for energy. So this the single layer phospholipid membrane has components which is going to degrade the triglycerides and release free fatty acids and glycerols. These free fatty acids and glycerols are then going to go to liver and then form energy. Okay, so this is how physiologically our nutrients are stored when they are in excess, and when in need they are going to be released. Okay, this is what I have tried to show here. Causes of obesity. It is an interaction of genes and environment. As far as adults with obesities are concerned, the role of gene is polygenetic. Therefore, genetic factors play a major role in predisposing people to adiposity, as seen in identical versus non-identical. Okay. Therefore, for a person to develop obesity, energy intake must exceed energy expenditure in a manner that is sufficiently sustained to result in accumulation of large excess triglycerides in adipose tissue. The patient must be following a sedentary lifestyle, more and more energy intake, and very, very reduced physical activity. Ultimately, triglycerides are in so excess that ultimately leads to obesity. Okay. Now, the talk is going on genetic factors. So this statement, I love it. That is, assessment of severely obese children and adults should be directed at screening for potentially treatable endocrine and or neurological conditions, plus identifying any genetic conditions if present. So okay, if there is any obese child or an adolescent, then you must look into some endocrine cause, neurological causes, and genetic causes. We'll see in couple of slides. Before I show you the table which I have brought here, I have tried to brief you about what all we are going to discuss. This is a like image of syndromic obesities wherein genes are defective. One such is Prader-Willi syndrome. As we all know, is an imprinting defect, paternal loss of the gene, where on chromosome number 15, leading to the infant developing hypotonia, small hands, short stature, hyperphagia developing during early childhood, hypogonadotrophic hypogonadism, and mental retardation. This is an image of Prader-Willi syndrome. This is an image of Bardet-Biedl syndrome. Bardet-Biedl syndrome classically showing polydactyly and overweight child. Every child is going to be ultimately overweight because obesity is going to kick in because of hyperphagia. But the main and the most common thing in all this is there is going to be some hypothalamic dysfunction going on. As we have seen, let me show you again. This was the very, very important slide. Okay. Any problem in this circuit, any problem in hypothalamus ultimately is going to disrupt our satiety center. And you know that hyperphagia and obesity will kick in. So this is an image of Bardet-Biedl syndrome showing an overweight child, polydactyly, retinal dystrophy leading to visual loss, hypogonadotrophic hypogonadism because, as I said, hypothalamic dysfunction, and renal dysfunction also. So Bardet-Biedl syndrome. Then this is Alstrom syndrome. Again, here there will be an overweight child showing early development of early type 2 diabetes mellitus, progressive cone and rod dystrophy. So there will be visual impairment, also sensory neural hearing loss. So basically, what I'm trying to say is these are all the syndromes wherein there will be developmental delays, there will be facial or any kind of dysmorphisms plus obesity. Okay, then Cohen syndrome. Again, here there will be facial dysmorphism, microcephaly, overweight child because there will be hyperphagia. Then in here, as I said, Carpenter syndrome, craniosynostosis will be a very peculiar finding in Carpenter syndrome. There will be brachydactyly, short fingers, congenital heart disease defects will be there, and intellectual disability. It was in a nutshell. Now we are going to discuss this genetic part of the obesity in a whole. Like clinically, we categorize genetic obesity syndromes into two parts. The first is with dysmorphism or developmental delays. Any child, any adolescent, if there are developmental delays or any dysmorphisms present with obesity, then there are these differentials that should be kept in mind. The first and the most common is Prader-Willi syndrome. As I said, it is a loss of paternal gene expression on chromosome number 15 affecting our hypothalamic dysfunction. Okay, so as you can see in this overweight child, mentally retarded, developmental delay, small hands, hypotonia, these are the features. It is an autosomal dominant condition, so only a single inheritance is enough to create a disease. So clinical features we have discussed. What is the confirmatory test? Confirmatory test for Prader-Willi is DNA methylation of chromosome 15q 11 to 13. Treatment is with growth hormone therapy. Yes, it has shown results, and as in Prader-Willi there is hypothalamic dysfunction, there will also be reduction in growth hormone releasing hormone. Thereby, growth hormone therapy will ultimately increase the lean body mass, reduce the body fat, and it will be overall symptomatically good for the patient. Then strict food control, sex hormones replacement at puberty, and behavioral treatment. These are all the things that we can do for Prader-Willi. Then the second important thing is Bardet-Biedl syndrome. Bardet-Biedl, it is a celiopathy. It is primary cilia is defect. Cilia required for leptin receptor in hypothalamus. Okay, ultimately there will be leptin resistance and hyperphagia and obesity. So again here if you can see is an obese child with polydactyly, retinal dystrophy, renal dysfunction, visual loss. These are all the features of Bardet-Biedl syndrome. It is an autosomal recessive condition. So confirmatory test, you have to do a genetic sequencing whole panel because there are going to be more than 20 Bardet-Biedl syndrome genes, and therefore the whole panel should be advised. Treatment is supportive. In all these cases there will be largely supportive treatment only. Regular renal monitoring, ophthalmology follow-up, hormone replacement at puberty, and manage CKD if it kicks in. Third and the important one is Alström syndrome. Alström's is also a celiopathy, autosomal recessive condition. Here there will be a progressive cone and rod dystrophy. Therefore, visual issues will be there, hearing issues will be there because there will be sensory neural hearing loss. Early type 2 diabetes mellitus and dilated cardiomyopathy. The gene involved here is ALMS1 gene. Therefore, its sequencing will tell us that it is Alström syndrome. Also, we can do an echo, we can do an audiometry, a fundoscopy to check for the eyes. Treatment, early aggressive diabetes mellitus management should be done because in Alström there will be an early type 2 diabetes mellitus. Hearing aids, heart failure management, weight management. Weight management is going to be applicable for all. Okay. Also behavioral treatments applicable for all. and monitor the fibrosis, because there will be hepatic and renal fibrosis. Then Carpenter's syndrome. Again, it is a celiopathy, autosomal recessive condition where there will be craniosynostosis. Again, overweight child with craniosynostosis, premature fusion of the skull bones, brachydactyly, small fingers, okay, and congenital heart defects. The gene involved is RAB23 gene. Also, you can do CT skull for craniosynostosis. Surgical correction of craniosynostosis is a part of our treatment, weight management, and developmental therapies. Okay, so this was all about genetic obesity syndromes wherein there are developmental delays plus or minus dysmorphisms with obesity. If there is no developmental delay, if there is no dysmorphisms, and this child or adolescent is having obesity, then these are the differentials these are the genetic reasons that you should keep in mind. The first gene affected is leptin gene, LEP gene affected. You can do a genetic sequencing, find out. It is an autosomal recessive condition. Again, I would like to reiterate this whole, yes, this whole image is very, very important. Anything affecting here, as I said, one, two, three, four, everything we'll discuss. Leptin gene affected, there will be deficiency of leptin, hyperphagia, obesity. Similarly, leptin receptor gene mutation not working properly, hyperphagia, obesity. So, this is what we are discussing here. Okay, leptin gene, severe hyperphagia, obesity. Again, because leptin gene to be affected, ultimately will have hypothalamic dysfunction, and so hypogonadotropic hypogonadism, mild hypothyroidism. Treatment of this condition is with recombinant leptin. Metrelleptin is the name of the drug, metrelleptin, which is a recombinant leptin. Then gene affected in leptin receptors, LEPR gene. So there will be leptin will be normal, leptin will be high, but these receptors are not functional. Again, it is an autosomal recessive condition. Severe hyperphagia, obesity, hypogonadotropic hypogonadism, mild hypothyroidism. Treatment here, metrelleptin will not work because leptin is already present. The defect is in receptor. Setmelanotide. It is an MC4R agonist. Setmelanotide. I'll zoom it here. Setmelanotide. It is a MC4R agonist. Okay. Then POMC. If POMC gene is affected, then there will be low ACTH, low cortisol, autosomal recessive condition, and there will be hyperphagia, cholestatic jaundice, pale skin. Yes, because remember, POMC was the one who was releasing alpha and beta melanocyte stimulating hormone. If this is not functional, there will be pale skin, red hair. Setmelanotide is a MC4R agonist, is going to be useful in this treatment. Fourth one which I want to discuss is melanocortin 4 receptor gene affected. It is the most common monogenic obesity syndrome that is commonly found. Then it is an autosomal dominant condition. Here again, hyperphagia, accelerated linear growth. Treatment is with GLP-1 agonist, lifestyle changes, and bariatric surgeries if applicable. Okay. And then also one word each for single-minded one and BDNF that we have discussed. So in all, there will be hyperphagia leading to obesity and concomitant features. Obesity secondary to other disorders. The two things you have to keep in mind. First is endocrine disorders. Endocrine disorders, that is hypothyroidism. Yes. So always check for the thyroid function test. Second is Cushing's syndrome, wherein there is hypercortisolism leading to obesity. What are the clinical features? Spontaneous bruise, livid striae, buffalo hump, red cheeks, marked centripetal obesity, myopathy. These are all the features of Cushing syndrome. What are the investigations you are going to do? You are going to do a 24-hour urinary free cortisol or give us dexamethasone suppression test, challenge test. Okay, this is the Cushing syndrome. The third is insulinoma. So these are all the endocrine disorders which can lead to obesity. So in order to evaluate obesity, so again, this is just a pathobiology of obesity. We evaluation and management we are going to discuss in detail in the next video. Okay. Secondly, hypothalamic damages due to any reason, say for example tumor such as craniopharyngioma, inflammatory masses, or severe head injury can lead to obesity. As I said, hypothalamus was our central integrator. If disruption in hypothalamic pathway, it is going to lead to obesity. What will be the clues? Clues will be there will be concomitant disruption of anterior or posterior pituitary hormones. Yes. What are the adverse consequences of obesity? Before looking into this picture, I would like to tell you that insulin resistance is one of the earliest complication of obesity. Then everything follows. Okay. So in this figure, if you can see, obesity leads to obstructive sleep apnea, a very atherothrombotic state that results from obesity can lead to stroke, even to coronary ischemic heart disease. Arterial disease can lead to dementia, hypertension, hypertriglyceridemia, heart failure, cancers. As I said in the beginning only, that obesity has overtaken smoking as the greatest risk factor. It can lead to cancers of esophagus, endometrium, pancreas, kidneys, PCOS. Then it can lead to development of diabetes, non-alcoholic fatty liver disease, and even it can lead to NASH, non-alcoholic steatohepatitis, reflux esophagitis, gallstones, arthritis and osteoarthritis and gout. These are all the complications or consequences of obesity. So what I want to make you understand is, first is mechanistic considerations. That is, first abnormality that develops in obesity is there is going to be increased circulating concentration of insulin to maintain the glucose homeostasis. Okay, but then at one point of time there will be insulin resistance, which leads to metabolic, endocrine and cardiovascular diseases. So our star molecule, yes, the main thing to remember here is insulin resistance. But how does obesity cause insulin resistance? So basically there are two theories which Harrison gives. First is, as adipose tissue storage is full, it can no longer take excess calories. So it can no longer now take triglycerides. So therefore now ectopic lipids in tissues such as muscle and liver. So there will be development of fatty liver, okay, which are not primarily designed to store nutrients. These are non-professional cells. Fat cell was a professional cell which used to like take in excess calories. These are not non-professionals. Ultimately leads to development of insulin resistance. The second theory is macrophages or inflammatory cells which are abundant in the adipose tissue. Through paracrine or endocrine mechanisms, they disturb the insulin's action on liver and muscles, ultimately lead to insulin resistance. Last slide of the day, our metabolic complications. Nothing new to read here, but first thing what I want to highlight here is obesity has overtaken smoking as the greatest risk factor for developing cancer. Dyslipidemia, it is characterized by increased circulating triglycerides and LDL. Fatty liver disease, as we knew that ectopic lipid deposition will lead to fatty liver and ultimately to NASH. Type 2 diabetes mellitus because of insulin resistance. Okay, a very common complication of obesity, a very common complication of obesity. Then dermatological complications such as with respect to insulin resistance, there will be acanthosis nigricans. Cardiovascular complications such as CAD, stroke, heart failure. CAD and stroke are due to atherothrombotic vascular diseases because of obesity. Respiratory complications such as obstructive sleep apnea, exertional dyspnea. GIT disorders such as reflux esophagitis, gallstone formation, cholecystitis, pancreatitis, and CA gallbladder. Rheumatological disorders such as osteoarthritis of knee, gout, and lastly, but very important, cancers of esophagus, pancreas, gallbladder, etc. BMI increase by 5 increases the risk of cancer by 10%. I think this much shocking statement is enough for the day. And yes, thank you guys. Thank you guys for listening me out. Hope you have a very nice day. Thank you.